Current Insights in Antithrombotic Therapy. A discussion of the American College of Chest Physicians' current consensus and its clinical implications in the management of embolic consequences in patients with atrial fibrillation. Let's join the discussion.
I'm Mike Ezekowitz. I'm a cardiologist. I'm professor of medicine at Yale University School of Medicine. I'm also the National Principal Investigator of the Veterans Administration Stroke Prevention Study, which has been designated SPINAF. The purpose of this presentation is to illustrate in a case report some of the recommendations of the American College of Chest Physicians, and also to illustrate some of the findings of the recent published studies on atrial fibrillation. I have two colleagues with me today. Dr. David Sherman is professor of neurology in San Antonio, Texas, and also is associated as one of the major investigators in the SPAF study. And I also have Dr. Greg Albers, who is also a neurologist from Stanford. He's assistant professor of neurology at Stanford and is associated as one of the investigators of the BATAF study. Dr. Albers has a case that he would like to present to us. Greg.
Thank you. I'd like to tell you about a patient that was referred to me a couple of weeks ago. This is a 71-year-old retired high school principal who has a 12-year history of paroxysmal atrial fibrillation. The patient first became symptomatic 12 years ago when he was leading a cheer at a high school game. At that time, he felt dizzy and had an unusual sensation in his chest and was found to be in atrial fibrillation with a rapid ventricular response. The patient was treated with Joxin, had good rate control, became asymptomatic, but intermittently over the next few years, he was noted to be in atrial fibrillation. He wasn't symptomatic again until 1985, when again had episodes of lightheadedness. His ventricular response was about 80 at that time. He was treated with cardioversion, but unfortunately only stayed in sinus rhythm for about 3 weeks and has gone back into paroxysmal bouts of atrial fibrillation ever since then. His past medical history is remarkable for intermittent claudication, and 3 years ago this was treated with a femoral angioplasty. At that time, he also had an echocardiogram which revealed mild biatrial enlargement and some mild global left ventricular dysfunction. As you know, it's very frustrating because we don't have good studies that look at anticoagulation and cardioversion. There have been some studies that have made it fairly clear that the risk of embolization related to the cardioversion or the weeks following the cardioversion, the risk of embolization can be reduced substantially by anticoagulating the patient. So what we recommended was that the patient should be anticoagulated for a month. It's substantial risk, despite the fact that they're an intermittent fibrillator, and particularly when you add in the fact that there is this, what appears to be a mild cardiomyopathy. So then the decision had to be made between recommending therapy with warfarin versus aspirin therapy. On the basis of Dave's study, the SPAF study, it appears that aspirin provides a benefit, although the Danish trial that also looked at aspirin was unable to document a benefit. So I think there's a little bit more question about how effective aspirin is in this setting, where we have 5 trials that have found warfarin to be highly effective. And since this patient had no risk factors for bleeding and was a reliable patient, I thought he would be best off on therapy with warfarin. So we prescribed Coumadin.